So basically, I don't think that Hodgkin lymphoma or transplantation for Hodgkin lymphoma has any special characteristics in this COVID-19 pandemic. But the reality is that transplantation is quite an immunosuppressive therapy, and it requires quite a lot of additional hospital resources. So in this sense, in this period of time, what we have done is to try to decrease as much as possible the number of transplantation and just to keep transplantation for those patients where the treatment was really urgent. So it depends a little bit on the disease status of the patient. So if we have a patient that it's in a very good or it's in complete remission, we can eventually give, for instance, an additional cycle of chemotherapy just to try to delay transplantation for 1 or 2 months. If the control of the disease is not so good, I mean, we may want to take the risk and go ahead with the stem cell transplantation in spite of the potential problems that would eventually occur in this pandemic. So we try to balance pros and cons in every single patient. So basically, for a transplant center, and we are a transplant center, I think that there are international and European and national guidelines regarding how we have to deal with transplantation in these patients. So for transplant centers, what basically I have said, just to evaluate pros and cons of doing the stem cell transplantation during the pandemic. For non-transplant patients, I think that there has to be an excellent connection with your transplant center just to figure out when for a given patient is the best time for transplant. So there should be quite a lot of coordination between non-transplant and transplant center, not to leave a patient in between both, in between of the system without doing anything with the patient. I don't think that there are any specific guidelines regarding which is the first-line treatment for these patients. So basically, in most of the European countries, ABVD is the standard of care for advanced stage Hodgkin lymphoma patients. There are other countries, such as Germany, and maybe other countries in Central Europe, and they are using BCOP escalated. Of course, in this specific situation, if you increase the intensity of the treatment, maybe you can assume that the patient is going to be more immunosuppressed and the patient might have more problems during COVID-19 pandemic, but this has not been really demonstrated. What I think it's important is the use of corticosteroids, because they are frequently used, of course, not in ABVD, but of course in BCOP escalated, and they are really immunosuppressive. And in other treatments, there are some general indications to try to reduce, for instance, the dose of dexamethasone, if it's possible to immunosuppress less the patients. Well, I think that, of course, if the patient has comorbidities before starting treatment, this is one thing that we have to take into consideration. It's also well known that bleomycin, which is one of the 4 drugs that is included in the ABVD protocol, has lung toxicity. So in principle, but this is only a theoretical answer. I don't think that nothing that I'm saying has been really proved. You may want to avoid drugs that are impacting lung function, because of course we know that COVID-19 can produce bilateral pneumonia. Well, if we are talking about ABVD-based protocols, you can eventually substitute bleomycin by brentuximab vedotin. That is, let's say, a protocol that has already been proven to be even more effective, for instance, in a stage 4 Hodgkin lymphoma patients. So one possibility would be to substitute bleomycin by brentuximab vedotin, so make it BB-ABD with the objective to avoid bleomycin toxicity if we really think that this might significantly impact the outcome of a patient being treated during this period of time. I think that the first consideration is that if we have somebody that has been diagnosed of relapse disease, we have to decide if this relapse is to be treated urgently, or eventually we can delay the start of second line or salvage chemotherapy. In most of the cases, this cannot be delayed. So the patient needs to be treated right away. So which are the precautions that we are using nowadays for these patients? We try, first of all, to avoid the patients coming to the hospital. So we try to minimize the visits of the patients to the hospital. So we have moved all the face-to-face visits to phone calls, so to try to avoid the patients coming to the hospital. Of course, the patient will have to come to the day unit to receive the treatment. If we can make any eventual modification in the treatment to decrease the number of days that the patient is coming to the day unit, that will be also very well received. And we have to be really very much aware about fever and signs or symptoms of respiratory infection to try to eventually early diagnose the COVID-19 infection. And of course, all these patients come to the hospital with masks, just as a way to be more protective. So we, of course, washing our hands, that's absolutely essential, and we are doing that all the day. We are using masks to visit our patients. In the inpatient setting, we are using these FFP2 masks, which are more protective, for ourselves, because of course the healthcare professionals need also to be protected. And for those patients that are being admitted, we are performing PCR tests to early detect COVID-19 infection. So the other important thing in this setting is that we try to keep as much independent as possible. Let's say all the patient flow for those patients that are COVID negative, and the patient flow for all patients, for these patients that unfortunately are COVID-19 positive, and we don't mix them at all in all the network of the hospital. So there is a small proportion of patients that are being treated either with nivolumab or pembrolizumab because of the disease status. In principle, we are not stopping this treatment, although we have to be aware that there might be increased immunological reactions during the treatment with checkpoint inhibitors of these patients, and these might eventually modify, all the cytokines cascade that basically at the end of the day are the responsible for the adult respiratory distress syndrome that COVID-19 might produce. Of course, if the patient is very well controlled, we might consider stopping it, but in some of the cases, the patients have active disease, and in principle, we prefer to keep them on.